All right, let's get right into it. Welcome to This Explainer. Today we're tackling one of the most frustrating, agonizing, and honestly misunderstood experiences in women's health. We are talking about chronic pelvic pain caused by adenomyosis. Now, if you or a loved one are dealing with this, I want to start by validating something absolutely crucial. The pain you are feeling is incredibly real, it's exhausting. But what happens when the traditional medical answer, which is usually surgery, doesn't actually cure the pain? Well, today we're going to break down the science of exactly why this happens, and far more importantly, how you can finally find some real relief. So here is the ultimate medical mystery for so many patients. I mean, imagine going through the massive emotional and physical toll of a major surgery like a hysterectomy or having diseased pelvic tissue excised completely with the hope of finally getting your life back. Yet you wake up in recovery, or maybe months down the line, and you're still suffering from the exact same severe, debilitating pain. How is that physically possible if the diseased tissue is literally gone? To really understand this, we need to look at a pretty brilliant analogy. It's the hardware versus software problem. When you have adenomyosis, the inflamed tissue in your uterus is the hardware. And surgery? Well, surgery is fantastic at swapping out bad hardware. But pain itself isn't actually processed in the uterus. It's processed in your nervous system, which is your body's software. If your software's alarm system has been stuck in the on position for years because of that bad hardware, simply removing the uterus doesn't automatically rewrite the software. The alarm just keeps on ringing, even when the intruder is long gone.
Which brings us to Section 1, Meet Nociplastic Pain.
Let's put a medical name to this software glitch. According to the International Association for the Study of Pain, this phenomenon is called nociplastic pain. And honestly, this represents a massive paradigm shift in how we understand human suffering. What this means is that your pain arises from an altered, amplified nervous system, even if there's no clear evidence of ongoing tissue damage right now. Through a process called central sensitization, your central nervous system essentially learns to amplify danger signals entirely on its own. So kind of picture how this builds. Think about traditional pain, what doctors usually call nociceptive pain. That's what you feel when you touch a hot stove or break a bone. It's acute, it's driven by active tissue damage, and when the tissue heals, the pain stops. Nocioplastic pain, on the other hand, is an amplified central nervous system misfiring. The pain is no longer just a symptom of a disease. The altered nervous system has actually become the disease itself. Section 2, the widespread symptom web. This totally explains why your suffering probably isn't just limited to your pelvis. See, your pelvis does not exist in a vacuum. The uterus, ovaries, bowel, and bladder all share the exact same nervous system inputs and pathways up to the brain. So when centralization occurs, it's like a massive power surge running through an entire electrical grid. The sensitization just spreads. This entirely validates why a patient with adenomyosis might suddenly feel like their bladder's on fire or their digestion is completely ruined. Because the central nervous system is so overactive, you'll notice patients frequently develop overlapping conditions. We're talking about things like irritable bowel syndrome, bladder pain syndrome, fibromyalgia, and intense migraines. You might also experience severe brain fog, intrusive fatigue, and sleep that just leaves you feeling completely exhausted. Listen, if you are experiencing these, it is not a coincidence, and it is certainly not in your head. It is physical proof of that amplified shared sensory web. Moving right along to Section 3, bottom up versus top down. Now, this is the exact clinical framework your doctors use to figure out your next steps. When specialists evaluate nocioplastic pain, they absolutely need to know if it's bottom up or top down. Bottom-up pain means your nervous system is highly sensitized, sure, but it's still being continuously fueled by an ongoing physical trigger down in the pelvis, like active adenomyosis inflammation. Top-down pain, however, means the central nervous system is now misfiring completely independently. It literally no longer needs the pelvic tissue to generate a severe pain response. So you might be wondering, why do some people develop this independent top-down pain while others don't? Well, risk factors just kind of compound across a lifespan. Genetics definitely play a role, but so do early life stressors, severe physical trauma, chronic poor sleep, and even just years of dealing with painful menstrual cycles. These factors all stack up over time, gradually priming the nervous system until it just gets locked into that hypervigilant, top-down sensitized state. And here is the absolutely crucial takeaway. If your doctor suspects your pain has become predominantly top-down, removing your uterus will not turn off the pain system.
If the pain is independent of the adenomyosis, surgery just puts you through a massive physical trauma, which, by the way, can actually further agitate the nervous system without giving you the relief you desperately need. This is exactly why expert specialists are highly hesitant to just rush you into the operating room.
Let's look at Section 4, Why Opioids Worsen Pain. This brings us to one of the most highly debated and frustrating topics in chronic pain management. If you've been referred to a pain specialist, they've probably told you that you need to get off your opioid pain medication. And I know exactly how terrifying that sounds. But listen to this direct quote from the clinical guidelines. The use of strong opioids is not recommended for nociplastic pain conditions. They can contribute to central sensitization and cause opioid-induced hyperalgesia. Opioids are the right tool for a broken bone. They are fundamentally the wrong tool for central sensitization. Let's break down exactly why. It's a physiological trap called opioid-induced hyperalgesia. It is this paradoxical phenomenon where, over time, the opioid medication actually induces chemical changes in your brain and spinal cord that make your nervous system more excitable. Literally, the drug actively trains your body to be more sensitive to pain. So when your doctor tells you to taper off opioids, it's not a punishment or them denying you care. It is a vital medical necessity to stop the drug from actively harming your nervous system. Section 5. Rewiring the pain system. Okay, so if surgery might not work and opioids make it worse, how do we actually fix this? Well, the gold standard of care is a multidisciplinary approach, which is perfectly illustrated by the strategy outlined in our source material by Dr. Leonardi. It's essentially a two-pronged attack. Step 1. Suppress the hormones. By stopping the menstrual cycle, you shrink the adenomyosis and cut off the local inflammation, removing that bottom-up trigger without the massive trauma of surgery. Step 2. Taper the opioids. This allows the central nervous system the space it desperately needs to finally hit the reset button and begin desensitizing. And once the system is ready to reset, we use top-down treatments that actually target the software. This includes neuromodulating medications like SNRIs or gabapentinoids, which boosts the brain's natural pain-relieving chemicals. It involves pelvic floor physical therapy to relax those hyperactive muscles that are constantly guarding your pelvis. We also use cognitive behavioral therapy to retrain the brain's danger signals, strict sleep hygiene regimens, and even novel therapies like low-dose naltrexone to calm the nerves. It really is a full-body approach to restore your internal brakes.
Chronic pelvic pain and adenomyosis are incredibly complex, but they are absolutely not impossible to treat once you understand the actual mechanisms at play. Your pain is real, your alarm system is stuck, and your hardware and software both need specialized, targeted care. So now that you are armed with a deeper understanding of how this central alarm system actually operates, how will you and your medical team work together to finally rewire it? Take this knowledge, ask the right questions, and boldly advocate for the comprehensive healing you completely deserve. Thanks for joining me on this explainer, and keep learning.